thank you very much for joining our session today on delivering PCN DES for 26-27 with a focus on sort of building smarter access across your network. So welcome today. Today's presenters are myself from Redmore Health, and I'm also joined by Anna Baxter from Engage Health. Just a bit of housekeeping before we start. So we are recording the session today, and your videos and microphones are being turned off just while we go through the presentation. If you do have any questions, please pop them in the chat and we'll either try and answer them or we'll go over them at the end in the Q&A section. And also a note that if you haven't registered for this session directly, so if you've joined via a link that was shared by somebody else, please just make sure that we've got your email address, job title and organisation in the chat, just so we can make sure you're invited to the D&C network where all of the information will be stored for you after this session. So all of the resources will be on the D&T network. You can join the network by either scanning the QR code that's on screen now, but after today, you will be sent an invite anyway, so you'll be able to access all the resources. So today, we're going to look at a bit of a PCN DES overview, and then we'll be looking into the front door as a PCN and how we can look at working at scale with practices and PCN. And then we're going to have a little bit of a demo from Engage Health from their platform, and then we can have some time at the end for questions. So the 26-27 PCN DES places a strong focus on these main themes. So the first is improving patient access. So with expectations being around faster responses, better triage processes, and keeping online consultation routes open during core hours, PCNs will need better visibility of demand and more consistent approaches across practices. The other theme is neighbourhood working and collaboration. So PCNs are expected to work more closely with neighbourhood teams, community services and wider system partners to deliver more joined up localised care and support that integrated neighbourhood working. There's also the workforce flexibility and hours. So the contract introduces greater flexibility with the hours roles, including expanded GP recruitment rules and more opportunities to share multidisciplinary teams around local population need. They look at prevention and population health management. So there is increased emphasis on prevention, reducing health inequalities and using population health management approaches to proactively identify and support patients most at risk. We're looking at digital transformation and modern general practice access. So digital tools, modern telephony, online consultations and smarter workflows continue to play a key role in improving patient experience, access and operational efficiency across PCNs. And then performance, data and continuous improvement. So the DES places greater importance on measurable improvement, with PCNs expected to use data, access metrics and patient insights to monitor performance and drive ongoing service improvement. So looking into improving patient access, so the contract continues the focus on modern general practice access principles, with practices and PCNs expected to improve responsiveness and manage demand more effectively. There's a strong emphasis on ensuring patients can access care through a range of routes, including that keeping online consultations open during core hours and providing same-day responses for urgent requests. The contract also highlights the importance of consistent triage and care navigation processes, helping those patients to get to the right service the first time and making better use of the wider workforce. And alongside this, practices and PCNs are encouraged to use data more proactively to understand the demand, to identify pressure points and improve the visibility of capacity across the network. So overall, the aim is to create a more coordinated, responsive and patient-centred access model that improves both patient experience and operational resilience. Now, neighbourhoods. The direction for primary care places increases the emphasis on neighbourhood working and collaboration across all services. And PCNs are being positioned as key neighbourhood delivery organisations, working more closely with community services, local authorities and wider system partners. There is a strong focus on integrated multidisciplinary working, with practices encouraged to share workforce, resources and expertise across neighbourhoods to improve patient care and operational resilience. And the DES also supports more joined up approaches to communication, care delivery and service planning, helping teams work more consistently across organisations and reducing fragmentation for patients. The hope with this is to create stronger place-based partnerships that can deliver more coordinated, proactive and patient-centred care at a neighbourhood level. Now, the workforce flexibility and Rs still continues to be a major part of the PCN DES, and it's also now got greater flexibility introduced around how roles can be used to support local priorities and patient need. There's also increased flexibility around GP recruitment, giving PCNs more opportunity to shape workforce models that work for their population and operational pressures. The contract continues to encourage the development of multidisciplinary teams, helping practices make use of that wider workforce and ensuring patients are supported by the most appropriate professional. And the direction supports more sustainable workforce planning, better use of capacity and the greater ability for PCNs to adapt services around local demand and that new neighbourhood way of working. The 26-27 contract also has an emphasis on prevention, early intervention and proactive care, with PCNs expected to take a more population health focused approach to service delivery. There is a strong focus on using population health data, risk stratification and targeted interventions to identify patients who may benefit from additional support before their health needs escalate. The contract also continues to support work around reducing health inequalities, including a focus on the core 20+5 priorities and improving outcomes for underserved communities. So it's encouraging PCNs to move beyond reactive care towards more proactive, data-driven approaches that will improve long-term health outcomes and support healthier populations. And digital transformation continues to underpin the direction of primary care, with PCNs expected to support more modern digital-first access models for patients. Now, there is a continued emphasis on using integrated systems, online consultations, and modern telephony solutions to improve access, manage demand more effectively, and reduce pressure on practice teams. And the contract also encourages smarter workflows, so better use of automation and improved patient communication through a range of digital channels, including messaging and those online services. So the aim here is to create more effective, responsive and patient-centred services through the use of better digital tools, data and technology-enabled ways of working. And the PCN DES includes a stronger focus again on performance monitoring, measurable outcomes and demonstrating impact across PCNs and neighbourhood services. There's an increasing expectation for organisations to use access, activity and patient insight data to identify opportunities, to monitor delivery and to support more informed decision making. It's trying to encourage a culture of continuous improvement where data is used not only for reporting, but to improve workflows, patient experience and operational resilience over time. And these will support more evidence-based service delivery, helping PCNs to demonstrate impact, track progress, and continuously improve care and access models. So the direction of travel for PCN DES. The changes to the DES reflect the wider NHS shift towards more proactive, neighbourhood-based care delivered through multidisciplinary teams and integrated access models. It's moving away from reactive, practice-level delivery and towards more coordinated models that improve access, make better use of the workforce capacity across the PCN and support that delivery at scale. And there is an increasing expectation for PCNs to work collaboratively across practices using shared workforce models, shared access approaches, and more consistent operational processes to manage the growing demand. But it also recognises the increasing pressure practices are facing from telephone demand, online consultations, and care navigation, encouraging networks to adopt more joined up and sustainable ways of working. The focus is on creating more responsive, integrated and resilient neighbourhood services that improve patient experience while supporting practices to manage operational pressure more effectively. Now, most practices now have multiple routes into care, so that's telephones, online consultation tools, walk-ins, messaging platforms, the NHS app, enhanced access hubs, but the challenge is that these routes often operate independently rather than a single integrated access model. And in many PCNs, there's no shared triage process, consistent routing model, or visibility of total demand across the network. Practices may also be triaging patients who could potentially be seen through a PCN level service, so the enhanced access hub, or by shared ARS roles working across multiple practices. And that can create additional pressure for practice teams who are required to manually navigate and redirect patients between services rather than working with a coordinated operational model. Many PCNs have made significant investment into ARS roles, but the operational impact is often less transformational than expected. In many cases, the challenge is not the workforce itself, but it's the access models surrounding it. Patients still naturally default towards GP appointments because this remains the most familiar route into care for them. But ARS roles can become additional services sitting alongside those core access pathways rather than being fully embedded into them. A more mature PCN access model would integrate ARS roles directly into triage and care navigation processes, standardise routing criteria, and provide clearer visibility of demand and outcomes across the network. So the result could be a fragmented experience for patients who might feel more like they're being passed between services rather than supported through a joined up system. And I know that most PCNs understand the vision set out within the DES and the wider NHS direction of travel. And the challenge is that the operational reality often still looks very different. So while the expectation is for network level working, shared workforce capacity, efficient routing, and consistent patient experience, many PCNs are still operating through separate practice level queues, inconsistent workflows, and manual care navigation processes. And this creates duplication, inefficiency, increased workload, and underutilisation of the wider workforce, while also limiting the visibility of demand across the network. So as a result, patient experience can vary significantly between practices, and PCNs can struggle to function as true population-based delivery models operating at that neighbourhood scale. So just a quick poll, if I can find it. I can't find my poll. If you could pop in the chat, it'd be really useful to know where you think most of your demand is currently managed, is it at practice level, or have you got your demand managed at a PCN level? Aha, there is the poll.
Just launched it.
Thank you. Just to get a feel of where everyone's sitting, I can see quite a lot is practice level. Yeah. Yeah, some mixed. Yeah. That's fab. So yeah, the PCN DES is all about moving towards a more collaborative model. So moving it to a PCN based model. So PCNs can move beyond simply offering multiple access routes and instead focus on managing demand intelligently across the network. A shared digital front door means that patients experience consistent access and communication regardless of which practice or channel they use, supported by coordinated workflows, standardized triage, and shared routing rules. And at PCN level, this means requests are managed consistently regardless of the practice. Capacity becomes visible across the network, and patients experience clearer communication and more coordinated care. So these shared operational models also improve resilience by allowing networks to flex workforce more effectively to balance that demand and reduce some of the pressure hotspots. And then consistent triage helps ensure urgent need is identified appropriately while reducing variation between each practice. Smart demand routing allows patients to be directed to the most appropriate professional first time, improving the use of those ARS roles and reducing unnecessary GP pressure. Now, the visibility of demand across the network supports better workforce deployment. So that capacity planning and that operational decision making, it becomes increasingly important for neighbourhood working and proactive care models. Effective communication and messaging also plays a key role by reducing that avoidable contact, but improving patient confidence and helping practices manage expectations more consistently is one of the messages that they want to get across. Now, digital tools are an important part of the modern primary care access models, but technology alone is not the solution. The operational model needs to come first. Without consistent workflows and agreed triage rules and shared operational processes, adding more digital channels can simply increase complexity rather than improve access. And the best outcomes occur when digital tools support that structured demand management, the coordinated workflows, and the better operational visibility across the network. And this includes supporting that intelligent triage, integrating shared workforce models, and enabling scalable access approaches that work consistently across the practices and PCN level services. And when digital tools are aligned to a clear operational model, they can help improve that communication, reduce duplication, and support smarter routing and give PCNs better visibility of demand and capacity across the network. And also from a patient experience perspective, they then get a smoother journey. They don't feel like they're getting passed from one service to another. So this is an example of the type of approach that can support PCNs as they move towards more coordinated access models and neighbourhood style working. And the focus here isn't adding more technology for the sake of it, but on helping practices and networks manage that demand more consistently and intelligently across multiple access routes. So platforms like this Engage Health platform can help create a more coordinated digital front door, bringing different access routes together into a single operational view. And that can support smarter triage, and it can improve that visibility and help practices communicate with patients more consistently. And from a PCN perspective, This type of approach may also support greater resilience and scalability over time by enabling more joined up ways of working across practices while still allowing flexibility locally. So I'm going to now hand over to Anna, who can give you some examples of how Engage Health can support that PCN level working.
Brilliant. Thank you, Claire. So with Engage, we obviously help PCNs deliver a more joined up approach, and we already are working with PCNs doing this. So whether that's dealing with their care home requests or actually just helping managing that demand across their patch. So I'm just going to share my screen and show you how this looks in a test system. So you should be able to see my screen now.
Yep.
Perfect. So one of the key capabilities of Engage, and we've had it for a while because we've always believed, a joined up way of working and approach is the best way to go. So we have a feature called cross-organizational working. So what that means is you as a PCN might have your own consult, so where you go in and deal with requests, but actually you want to view requests across your networks, across your practices. So on the left-hand side here, you'll see we've got the PCN inbox at the top here, and then we've got our practices. And what can happen is the practices can choose what group they want to share with the PCN and vice versa, or with each other, to really help manage those requests and get into the right person at the right time. So just to show you a few examples on my screen, we've had an asthma review form come in from a patient. You can see which practice this has come from and where it's actually gone to. So this has gone to the asthma nurses from practice 1. We have diabetes request come in and it's gone to practice 1 from practice 2. So there's different ways you can work the system to ensure your requests go to where they need to go. And this could work for pharmacists as well. So our medication reviews are going to the pharmacist at the PCN. So with the cross-organisational working, you would pop in data sharing agreements in place so you can share those requests freely from patients and then ensure they go to the right role. So for example, if in one practice you had an asthma nurse, in practice 2 you had a diabetes nurse, you can actually share that workload rather than having to have a specialist in each practice. So if I just click into one of these requests, so this is a medication review, for example, you can see the patient's request come through, obviously all the clinical codes attached as well. You could then message that patient, whether you're the PCN or practice, if you needed more information. So you can go in to message that patient, add any attachments, etc. But also at that point, you might want to actually allocate them an appointment or send them an appointment booking link. So you've got all the features you need to utilise, so you're not having to go to other systems to contact that patient. You can also do this internally as well. So you might actually want to add a note for the practice to review and send that back to the practice to action. You've got that two-way communication from the practice to the PCN and between each other. And when I'm ready, you can just send that to the clinical system from one click and it would all go in fully coded into the system. And at that point as well, I can actually add an outcome, which is obviously great for when it comes to your reporting. So that just shows some of the ways requests can come in from patients. These can be navigated, as I mentioned, and that can be on request type. It can be on medical problem. It might be that particular patients are high risk, so you want them to come into the system, routed to a particular group, and also marked as urgent. So you can really narrow in and make sure those requests are going to where they need to go and with priority set as well. So as you can see on the left-hand side here, some of my requests are marked as urgent, routine, same day, and then you can then order by that list so you can make sure the most urgent requests get seen first. So PCNs at the moment with Engage, there's a variety of different ways they work and utilise the system. So some of the ways are helping practices with their demand that's coming on via online, because with Engage, might be on a total triage model, so all requests are coming into the system. We also have telephony integration as well, so it can come through the telephone into the system, and they can help you manage that demand. We have other PCNs dealing with care home requests, so that's a really popular one. It can make it easier for the care home to submit requests, so they would go via the patient portal. So if I just show you what that would look like. So obviously this is just a demo site, but you can have the patient portal. You can have it as a PCN. You might have them go through the practices patient portal and routed to the PCN. It depends on how you want it set up. But the care homes can go in and submit requests on behalf of the residents. So that might be a general medical request, or it could be a ward round request, UTI, etc. Now, the great thing for the care home is they can access this at any time of the day if you allow them. It's down to obviously the PC and the practice. Obviously, it would replace emails, phone calls, so it creates just one communication channel from the care homes to the PCN or practice. And they can also download that request, which is great for their CQC, sorry. There's different ways it benefits the care homes, but also benefits the PCN and practice because those requests come straight in. So if I go back to where the requests come into Engage, and then they can either assign them to who needs to deal with them, create a ward round list, or if they need to go back to the practice, they can send them back. So it's really popular with our PCNs way to manage care home requests. It creates one communication channel, as I mentioned, so it's a lot easier for them to deal with it. There's other things as well that they can do. So you can build your own questionnaires into the system. Like you saw on my screen, the different questionnaires I had for the care homes to answer, and you can code them as well. So you really get the information you need back from that care home or patient to save so much back and forth, although you have got the messaging solution there as well. Obviously with our front door, so if I just pop the patient portal back up on the screen, this can all be configured. So this could actually be done on a PCN level. So there might be self-referral links that you want all the practices in the PCN to offer, whether that's online health advice, maybe online health reviews, which can then all come fully coded into the system. If I go back to the client. So the main reason we done this was to help PCNs obviously through your demand, because you can see the requests coming into the practices. You can also obviously share those freely without having to go in so many different places. You can also send an outbound message. So if you're dealing with your practices campaigns, for example, you can actually go in as a PCN and send out those campaigns. So it can take a lot of the workload from the practices, obviously depending on what resources you have. And also, I think the key one as well is sharing resources as well around the PCN. So if I just go back to the slides. Thank you. So one key point that everyone wants to know is around your reporting. So reporting is obviously important to see what requests are coming through the system, what ones are being directed to the PCN and vice versa. So we offer a reporting dashboard, which either practices can view or the PCN can have an overview of the practice's demand as well. And it covers a variety of different things in the reporting, such as outcomes. So you can actually configure your outcomes in our management console. So then practices can choose what the outcome of that request was. Was it a face-to-face appointment, telephone, etc., which will then show on your reporting dashboards, see what patients are utilising the system and what for. And from there, obviously, you get metrics of kind of how you can enhance the service, what you need, and how to expand. We've had really great feedback as well from our PCN. So I've just popped one on the screen about how it's worked for them. So this PCN have always dealt with their care home requests, for their practice requests. So they've helped their practices with their online demand, and they've recently introduced the care home requests coming through to the PCN as well. So as you can see from their quote, it's improved the way the team are able to work. They can actually structure the information as well that comes back from the care homes, and it makes it a lot easier for them to deal with the requests as well. So that's just kind of an overview of what Engage can do how you can utilise that cross-organisational working and care navigation rules to make sure the requests go to the right person at the right time without having to go in so many different systems, and also just assigning those at a click of a button or having the system do it for you.
Fab, thank you very much, Anna. That was a really good overview of Engage, and I'm sure you can all see how that can benefit you at a PCN level way of working. So the key takeaways for PCN DES is that it requires operational change. The challenge is no longer simply adding services, it's about creating that scalable operational models. Access is the enabler. So access sits underneath patient experience, workforce optimization, responsiveness, care coordination, and neighbourhood delivery. And that demand must be structured. So without that structured demand, workforce models fail, variation increases, and capacity becomes inefficient, and GP pressure will just continue. And then that network level thinking is essential. So the future model of primary care requires coordinated workflows, shared operational approaches, I can't get that out, scalable access management and population level delivery. So PCNs that develop more mature access models now will be significantly better positioned for future NHS expectations. And the challenge facing PCNs isn't simply creating more ways for patients to contact practices. It's about creating that coordinated and intelligent way of managing demand across the entire PCN. And that's what enables this better access, better workforce utilisation, and better patient experience. And that's where operationally aligned digital solutions can make the biggest difference. I'd like to say thank you very much to Anna for joining us today, but thank you very much for you to join us today, and I hope you have a lovely rest of your day.